I'm here to present an integrative ethics review. The goal is to give you a good, clinically relevant and exam relevant summary of some of the topics we've talked about this term so that you're ready to provide good patient care and to do well on the exam. And what we're going to do, had this been in person, it'd be interactive, but since I have a cough, it's going to be in video, is to focus on the topics that I think are really critical clinically, and which will be on the exam, and of course, those should be the same thing. So the first case is a 16-year-old who is part of a Jehovah's Witness family who unfortunately suffers a splenic laceration during a car accident. And an intra-abdominal hemorrhage results in the ED. The father, sort of hearing that bleeding is happening, says, "Hey, just so you know, we're Jehovah's Witnesses and don't believe in receiving blood transfusions." And the ED physician is thinking that refusal of blood transfusion is going to become life-threatening, perhaps not like immediately, but in the coming few hours, so quite soon. This is splenic lacerations can lead to really dramatic blood loss. So the team calls an ethics consult about treatment over objection, giving a blood transfusion against the parental objection. So which of the following is the right step forward? The options are A, get the patient alone and ask her to explain what she prefers. B, tell the father there's no biological basis for an effect of blood transfusions on his daughter's soul. C, tell the ED physician that we respect the autonomy of patients who identify as Jehovah's Witnesses. D, administer the transfusion covertly. Or E, notify the Department of Children and Families of a suspected case of child abuse. So let me talk through why I think A is the right answer. One, test-taking skills. When you're taking an ethics question, if more conversation is one of the options, that's highly likely to be it. It's a bias we have. Sometimes the quick right answer is less wise than getting people together for consensus. But I think this also really hinges on what's wrong with the other options. So telling the father there's no biological basis for a religious belief is counterproductive and offensive and not something that people should do. You may believe that, and one could debate whether everything under the sun is explained by biology, but that's an inappropriate thing to talk about now. So this option is about professionalism. C, I think, has the veneer of professionalism, that we respect the autonomy of patients who identify as Jehovah's Witnesses. And this is certainly true for an adult patient with decision-making capacity who wishes to refuse a blood transfusion. On the other hand, the wrinkle here is this is a pediatric patient and an adolescent pediatric patient. And so there's this question out there of whether she can refuse. If this were a 6-year-old, the default response would be to give the transfusion to protect the livelihood of or the well-being of the child, in order to allow her to make a religious decision when she has capacity about whether she wants blood transfusions. Whereas, an older adolescent who is declining and can express why, similar to the parents, we may respect that refusal. So it really depends. And so this option can't be correct. D, administer the transfusion covertly. Covert treatment is almost always wrong. Deceit is not a medical tool. There are some incredibly rare circumstances in which one might do this with a patient who lacked decision-making capacity, but only as a last resort and with ethics overview, and even then with great ambivalence. Notify the Department of Children and Families of a suspected case of child abuse is an option I included because sometimes clinicians who are not Jehovah's Witness will bring this up because they're mystified why a parent would not want a child to get better, they think. And I think it's really important to know why this is wrong, which is that Jehovah's Witness parents, like almost all parents, care deeply about the well-being of their kids and want them to get better, and are feeling obligated religiously to carry through with their beliefs, and yet as parents they want to do the opposite thing, and so judging them or notifying the authorities of abuse just compounds that suffering, and so I think is the wrong idea. I think it's very important to help people understand the inner workings of this, that it's quite different from abusive parents. And so what questions would you ask the daughter? Partly this is a chance to review the elements of decision-making capacity. Does she understand what is being proposed and why, the benefits and risks of a blood transfusion, the rationale for giving it? Is she able to articulate them? Is she able to give a valid rationale for whichever way she leans? Is she doing it without coercion? So for instance, I would try to get her to speak alone and so that I can kind of hear an unvarnished response to the situation. And I guess sort of there's also the often forgotten criterion that she has to be able to communicate a question. Somebody who is cognitively intact could give a valid rationale, but for whatever reason cannot possibly convey a decision. Gosh, maybe in the abstract they have decision-making capacity, but if they can't communicate a decision, it's kind of immaterial. So I'd be asking, does she understand and what does she want and why, and seeing if they're reasonable responses and trying to honor which way she wants to go, kind of analogous to an adult, but noting that it's more complicated. And so this case is kind of a good example of the different steps that we reviewed at the beginning of this sequence in making ethical decisions. You need to get the facts. And so in this case, the key fact was how life-threatening is the bleeding and how much is it needed. And then another fact might be what other options are available. Sometimes clinicians can lean on non-transfusion options more in such a case. But most importantly, what did the patient think? And then I think it's important to do an ethical analysis. So here we're talking about respect for individual patient autonomy, but also parental autonomy in the case of a child. We're trying to be beneficent with our treatment. And non-maleficence comes in here too. We often forget sometimes some of the collateral damage of our well-meant treatments. So if this patient were treated against her and her family wishes, could it lead to a breach with the healthcare system? Could giving a transfusion to a Jehovah's Witness lead to separation from the community? Are there other reasons to second guess whether it's safe to get a transfusion? Of course, there are risks, et cetera. Have to consider that too. In this case, justice is relevant because we want to treat patients who are Jehovah's Witnesses with equal respect as those from other faith traditions. The decision making, I think, is an important part. Number 3 here is to say, what are the options? And I would say as an ethicist, I'm frequently presented with too narrow of a list of options. It's either respect this person or respect that person when the best option is not on the radar screen of those who are asking for help, like have them each reach a compromise. Once you figure out which ways forward, you negotiate what's possible, you achieve consensus. And then if there is some sort of learning point here, we teach and prevent so that hopefully ethical challenges don't come up as much in the future. The other thing this case illustrates is the spectrum related to decision-making capacity. And I wanted to make sure you're clear on the different spectra we talk about. So in pediatric care, we talk about assent, that we want a child for an optional medical care to kind of give their consent as their sort of bodily autonomy grows, not possible in a 2-year-old, but possible with optional care in a 10-year-old, say. But that's different from full adult consent. Another way to think about this is that patients who are adults can have a spectrum of abilities to consent. Some have full decision-making capacities, others have partial impairments and only can take the simpler decisions on, whereas others have no ability to engage with a thing. And so avoid binary thinking and kind of think about where on the spectrum is that child or is that adult. With parental decision-making, the spectrum can change into, in 99% of cases, we're abiding by the parent's preferences in a child's care. But there are exceptions that we focused on, such as when an adolescent wants private sexual care, which is legal, or in the case of this first patient here, where perhaps the parental preferences may conflict with the child's ability to live. Similarly, with surrogate decision makers, there might be a spectrum. If a patient has no decision-making capacity, we go to the surrogate decision maker for everything, hopefully with an advanced directive in place. But if a patient has sort of simple decision-making capacity, but with some impairment, we're going to go to the patient first for that, and then secondarily to the surrogate decision maker. It's an error I see on the ward sometimes that the surrogate, if present and needed for anything, takes over everything, and that's not the goal. Always go to the patient as much as possible. So case 2 is simple. This is alluding to the social determinants of health. Congratulations, it says, you are a perfect physician providing flawless healthcare to the entire population. What percentage of your patient's healthcare needs are you therefore addressing? And the perspicacious observers among you will notice that there is a hint on the slide that the answer actually is, it's not that you're a perfect 10, it's that it's about 10%. So that is hearkening back to this estimate. I think if you dig into this, if you look under the hood, the data behind this characterization are not the strongest. And so I think good people could debate what the percentages are accurately, and it probably depends on the situation. But I think the key take-home point is undisputed that things like genetics and behavior and social factors are much more impactful in our patients' lives than healthcare, or importantly, healthcare as it is today. And so I think the way to think of it is that in order to save lives, we have to blur the distinctions between healthcare from like a biomedical model and redressing the social and behavioral determinants of health. That means it's a call to physicians to engage more in public health interventions, to learn more about the behavioral determinants of their patients' health, to be more informed about the environmental, exposures, et cetera, that might be influencing their patient's health so that they can be more potent and do stuff. That should make 10% be kind of the floor of our impact and not the ceiling. Hopefully, a more informed, well-rounded clinician practice does more. And that links to foundational bioethics values that we care about justice, and so we want to lean in to those social factors. We don't want to only lean on the biomedicine that's going to largely help people whose health issues are not affected by such factors. But we need to do it in a way that is respectful of those patients' autonomy. We don't just gallop in on our charging steed and just try to take over that problem. This is the thing you'll see in clinic all the time, that we'll be sort of wanting to swoop in and just fix the problem. And it's like, no, work with the patient to deal with this, and don't pretend to have more power over social factors than you do. Wise resource allocation links to that too, because if you are partnered with the patient and you thus engage their participation, they're more likely to get it and to engage with you and to not feel disrespected by your work, and so it'll work better. Just as you would want to use yourself effectively, your time effectively by dealing with the true pathophysiology, and if it's social, focus on that. You also want to do that well. So we talked about this model of solidarity with patients, that we work with them on the problems they think are important in a way that's appropriate to their context, so that we're most effective and most respectful to them. And then I think importantly, we can't do that in a vacuum. That no physician knows all of the social context or has power over all those factors. No physician is familiar with all cultures that their patients will have, or free of cognitive biases. Sometimes, as an example, we might say, "Oh, I want to help my patient get better from that cold. So what the heck? I'm going to give them this antibiotic just in case it helps." Not being fully aware of the fact that giving unnecessary antibiotics causes patient harm more than helps patients, because it leads to toxicity and antibiotic resistance that maybe we don't see as directly as those coughing symptoms that led to the prescription. And so having oversight to protect patients from our mistakes is important. And so this takes lots of forms. It could be that I get feedback on my clinical outcomes and where I might have made mistakes. Could be that certain of my practices are overseen and mistakes prevented. For instance, antibiotic prescribing is often circumscribed in hospitals so that we can't waste the most last line antibiotics. And this can go to equity too. If we are noticing patterns of practice and differential practice by race or sex or whatever, that gives us an opportunity to fix it. And this is usually not visible to the individual clinician. It requires oversight. And so physicians need to understand that justice requires them to exist in such a matrix. Even if they are control freaks and want to have total control, they shouldn't. And so this gets in the space of public health ethics that we talked about a little bit, or this idea that respecting patient autonomy is almost always what we do, but there are exceptions. Sometimes patients ask for things that are not indicated, would be an example. And sometimes what's good for all might outweigh what's good for that individual patient. Just like in society, individual autonomy is not God, that we have speed limits to protect people from the harms of individual autonomy. That in medicine, there are examples of this too. An example might be that I'm going to get access to whatever care is indicated for me, unless it's in short supply, in which case maybe I'm not the sickest and not the one that needs it the most, and it'll go to somebody who needs it more. In this dynamic, I wanted to highlight this key pitfall that clinicians sometimes can fall into when we're thinking about the social determinants of health and how to allocate things wisely and who needs it the most, who's the sickest. We're using demographics to make these decisions, as we should. We can fall prey to this terrible purity that we talked about in class, that Helen McBride Johnson and Peter Singer's public dialogue best illustrated. This idea that sometimes clinicians can fail to understand the value in the lives of people who are just by chance very different from them. In the case of this exchange, people with disabilities. That Harry McBride Johnson, I think, made a compelling case that Peter Singer and others who sort of said, well, gosh, if we're going to ration, it would be reasonable to ration preferentially to people who don't have disabilities. Yeah, she made a good case that um, that undervalues the lives of people with disabilities. And so the version of this that you'll see in clinical care is that sometimes in end of life decision making, or clinicians will say, "Well, gosh, is that a reasonable intervention for that patient? It's not worth it," they'll say. And sometimes that's true. That it essentially cannot achieve a goal, and it is wise to not give that therapy anymore, to not give false hope. But other times, it's not worth it is a sign that clinicians are not valuing that patient's life. And so that's a clear form of bias we need to check. Speaking of bias, I wanted to focus on this question. What ethical justification is there for our hospital and others to treat the below scenarios differently, or I would say oppositely? A white man declines treatment from a black doctor due to the belief that she is not competent. That would be a request we would not honor. A woman who was recently assaulted by a bald man requests not to be examined by a similarly appearing bald doctor. And this would be a request we would honor if we could, if there were an alternate person available. So what's the ethical justification for this? I think at a surface level, the sort of adolescent response to this would say this is inequality that we're only honoring in some woke way. Well, I think we had a good conversation in class about the difference here, the difference which drives an appropriately different response is that the first request is a biased request. It is based on a biased perception of the clinician, whereas the second is about the patient, that the patient has something about them that we're trying to accommodate their trauma at the hands of somebody who coincidentally looks like the doctor they don't want to be examined by. Note that the latter, therefore, since it's not coming from bias, is something we try to honor, but we talk with the patient, and let's say if they're the only doctor available at the moment is somebody who looks like their assailant, we ask them, so, would you prefer to come back at a different time, or are you willing to deal with it if that's the only option? We have conversations. That's another moment of more conversations being good in the eyes of an ethicist. Case 3, you are the attending critical care doc. The general surgeon says your 69-year-old retired judge and widow needs a colectomy to address sepsis from a bowel perforation that's related to a newly diagnosed colonic mass. She's on broad spectrum antibiotics and high doses of pain meds, and as a result, her nurse says that old biddy is loopy. The patient, who is feverish and hypotensive, i.e., at life-threatening risk, declines life-saving surgery. She does not have an advance directive or any loved ones available. So the question is, which of the following patient statements would make you more likely to move ahead with the surgery despite her refusal, i.e., when is treatment over objection okay? 1, she says, I've lived a long and happy life. It's time for me to see my wife again in heaven. B, the surgeon says she's going to die if we don't act tonight. C, the nurse says she was hallucinating this morning. D, the patient says, can you get the squirrels out of my belly while you're in there? E, the oncologist says last week she had a hard time understanding the details of which chemo regimen to choose. So I think all of these might play a role, but the one that makes you more likely to do treatment over refusal is going to be B. That not only do we think that she's loopy, but if we don't protect her life in that state of impaired autonomy or capacity, she'll die. Note that we respect patients' bodily autonomy. Don't touch, no means no, as a critical thing, even if they don't understand the medical decisions. And so there's a high bar for being able to lean in to provide unwanted care, even if they are confused. But if it's a choice between respecting their autonomy and letting them die versus momentary transitory intrusion on their bodily autonomy that saves their life during a time of impaired capacity, then we would be willing to do it. Notably, we're not going to trade acne over somebody's objection, even if they are confused. And if they are not confused and are saying don't touch, then don't touch is the answer. Notably, the first one seems like a legitimate patient explanation of why they would, refuse care. And so, gosh, are they really impaired? That actually might make me go toward respecting them. The nurses in C report that she was hallucinating this morning isn't exactly pertinent because decision-making capacity changes by situation and time. D, the fact that she is clearly delusional does speak to her lack of capacity, but B is more important because if she lacks capacity, but it's not acute, it doesn't matter. I still wouldn't do it. And then E, like C, since decision-making capacity changes, I don't need to know that she was out of it last week. So treatment over objection in Vermont and in many places requires impaired decision-making capacity and an urgent threat to life and or limb. And then if there is a surrogate present, they need to agree with that. If they say, stop the presses, don't do it, then either way, we're still not going to do it. So respect for autonomy is decision-making capacity is decision-specific and changes by time. And just having a mental health diagnosis or cognitive impairment doesn't automatically exclude that person. You need to know, do they have those elements of consent? They have to communicate a choice, understand a decision, appreciate risks and benefits, and give a reasonable rationale without coercion. Hey, I just emphasized this twice. Seems likely that this is important. Case 4, you are concerned that Barney Stinson has neurosyphilis contracted at some point while having sex with dozens of sex partners he met during a pickup move that he calls the scuba diver. To confirm the diagnosis of neurosyphilis, which is in a standard of care fashion, you should do a lumbar puncture as depicted, putting a needle carefully in the right spot so as not to hit nerves or bones, pulling out some spinal fluid, and testing for syphilis. Sadly, though, Barney is delirious and can't consent for that procedure. He has no family or advance directives, but the upside is that his bed is ringed by former sex partners, all of whom want to help. And so the question is, which of the following sex partners is best suited to speak for Barney? So I'm asking you which meets the best, which is best poised to do the right kind of substituted judgment. The partner who A, had sex with him 3 times and says, I'm not ready to let him go. B, the partner who had sex with him once and said, he exposed me to syphilis, let him die. C, the partner who had sex with him 100 times and can't stop crying. D, the patient who had sex with him twice and says, he's a fighter, he would want that tap. E, the partner who rejected him entirely, but agrees saying he was all about tapping things. Or F, none of the above because they are not a family or legal agent. So let's find the right option. A is wrong because that person is speaking to what they want, not what Barney would want. That's kind of the same thing in B. C, there's nothing wrong with it. Doesn't like elevate that person's stature as a decision maker that they've had sex with them more times than the other people, but it completely takes them off the list of possible surrogate decision makers if they cannot communicate a decision. So just like with a patient who cannot communicate a choice, they essentially lack decision making capacity. Same with a surrogate. Same criteria apply. The patient who had sex with him twice and says he's a fighter, he would want that, is exhibiting substituted judgment. She or he is speaking to their estimate of what he wants. So that is the right option. E is kind of doing the same thing, but I'd say less clearly. So I guess I would pick D as the best option. And F, most of the time, people are not a legal decision maker. And it's not uncommon for that person to say be a girlfriend or boyfriend or something like that, and so that's a valid decision maker. They would be superseded by a legal decision maker if there were one, but we haven't heard of that. So the right answer here is D. So speaking of the hierarchy of decision makers, we always go to the patient if we can, and that includes their written risks, their written requests, even if they can't make them right now. An agent appointed in an advance directive is our second choice. A guardian is third choice. That's also a legal decision maker, but you may remember that they, by default, don't have the ability to withdraw life-sustaining therapy, so they have fewer powers. Substituted judgment of whoever knows that person well, and then if we don't have anybody to speak for the patient, we sort of try to guess what a reasonable person would do. We act in their best interest. In Vermont and 20% of the United States, there is no hierarchy of surrogate decision makers, but New Hampshire, New York, other nearby states do have one. So wherever you are, good to know what the law says. Advance directives can help represent the patient's voice if they indicate some preferences, but also it can identify, most importantly, who can speak for them best. And so we sort of have this hierarchy on the right that I displayed. And I would just say that oftentimes these things go together. Advance directives are most useful for identifying an agent. What the patient once said is critical to take into account and cannot be overturned by a surrogate. All of this has to be in the context of who this person was and what their values are, because inevitably the patient they face is probably not going to be written up in the advance directive. So what would they be willing to go through? What would they not? What do they care about in life? What are they trying to recover to is really what we care about. Whether we're talking with a patient or with a surrogate decision maker, we want to have high quality conversations. And particularly when we're doing shared decision making with a patient, we want to make sure our expertise is coupled with their expertise about their life and their goals. And so this is the acronym you may recall about how to conduct shared decision making, to seek their participation in that, because they may or may not know what that involves. Help them explore the options, how they link to their values and preferences, to cone down on a decision, and then make sure that they feel comfortable with it. So let's do that. Case 5 involves a 56-year-old bald infectious disease doctor who wants a hair transplant so I can look like Rob Lowe on the right. In further decision making, shared decision making, he says, "I miss my hair, doc. I miss my youth." While he sobs uncontrollably, and while you recall that hair transplants can restore hair growth, you consider the following question. Should you decline to offer a hair transplant on the grounds that it represents medical futility? And so the options are yes, hair transplants cannot treat baldness, which I just told you was wrong. B, yes, you should decline because hair transplants cannot make him look more like Rob Lowe. That feels closer to reality to all of us, right? C, yes, you should punish him for his vanity. That may be a sin, but perhaps not doctor's job to mete out moral punishments. D, no, it's his right to access the care he wants. If they want it, give it to him. I think some clinicians feel like that, but I would say that's wrong, that we should give care that will work and is indicated. And so the question here is not just whether he wants it, but whether it will work. No, a hair transplant will make him look exactly like Rob Lowe, and an example of that would be posted below. And gosh, it seems like there might be some differences, unfortunately. No, but clarify it'll make him look more like himself with hair. Okay, now I think we're essentially choosing between F and B. And I think F is probably the best thing because if he says, okay, I guess maybe a hair transplant's not going to fix the nose issue, but I'm still willing to go for it because it looks like the picture below. Great, there's your best option. On the other hand, is Rob Lowe or nothing? Then B is the option. And this is all me just kind of circling around physiological futility. You cannot make Tim Leahy look like Rob Lowe. Um, uh, or probabilistic futility. I could intubate your loved one in the ICU. I don't think it's likely to save their life, but could it be 1 in 1,000, 1 in 10,000? We almost never know with numerical precision about this, and there's always the ability to imagine a benefit. So this can be kind of useless as a metric. It leads down a rabbit hole. It leads to stasis. And so I think the best thing is qualitative futility. What would Tim want? He wants to look like a super famous star of Parks and Recs. Well, gosh, I don't know if that's possible, but would you like to be a little warmer in the day because you have more coverage on top? That's a reasonable goal, worth having some shared decision making about it. You've identified a reasonable goal of treatment, you would do it. If there isn't one, then don't. Case 6, Cindy, your wheelchair-bound patient with a history of suicidal depression, also with multiple sclerosis complicated by painful spasticity and the inability to swallow or protect her airway, says, life is miserable for me now. Despite all your efforts to control my discomfort, I have no quality of life. I'm in and out of the hospital, pain meds, antispastic, antidepressants. It's time for me to check out before I lose the chance to have some control. She asks you to participate in physician-assisted death or medical aid in dying. You think that she is likely to die in 6 months, perhaps from an aspiration pneumonia or malnutrition. She has decision-making capacity and appears uncoerced, but she is depressed. So notably, we discussed that physician-assisted death is legal in 10 jurisdictions, including the state of Vermont. Since that includes California, that's a larger than a fifth of the population of the United States. And the question is, which of the following criteria must be met for this patient to be eligible for physician aid in dying in Vermont? And I would say that the rules are not exactly identical by state, so it's good to know which state you're practicing in. But I emphasize Vermont, and they're all rather similar. So they all require a terminal illness. They all require oral and written patient requests. The idea is that it needs to be formal. This is a life-altering or ending decision. And it must be a consistent decision. You don't want it to be a fly-by-night thought. And so all of them introduce some sort of pause, a second request coming to kind of make sure this is a consistent decision. All of them introduce a second physician opinion about their terminal state. So a common dyad is the primary care physician and the specialist who diagnosed their, say, cancer or neurodegenerative disorder, or it could be a palliative care physician and one of those people. And then D, psychiatric evaluation. This is not always required. This is typically not required, but it is strongly encouraged when there's any doubt about psychological illness. Here, I think that's a concern. This patient may have a history of depression that's irrelevant to this, or it could be that they have, as part of their suffering, an uncontrolled psychiatric condition that we should try to treat first. And so here, I'd probably say yes, psychiatric evaluation is required, although that's not always required in all cases. E, in all cases, the patient must be able to self-administer. Functionally, that means move a medicine with their own hand to their mouth and swallow it, although You could imagine alternate ways that are not forbidden in the law, like if there were a machine that could administer the drug intravenously and the patient pushes the button, that would be legal. D, permission from a judge is never required from medical aid in dying. Essentially, medical aid in dying laws are permission from the state. And then D, remission of depression, that is also not required because a mental health diagnosis alone is not an exclusion criterion. So here, I think E is the right answer. Note that Vermont does not require Vermont residency, but most states do require residency in the state where it's happening. Nearing the end here, we've talked about abortion, medical aid in dying, some forms of cosmetic surgeries as controversial medical practices. Another might be participation in execution, which is, I'd say, is less controversial and largely repudiated by the medical establishment, but not 100%. When there is such controversies, the question is I think we often go to, well, which side am I on? And that's okay. Excuse me, but I would say also it's important to have other ethical practices so that that controversy is not inflamed, so that it might be lessened, so that we don't unnecessarily polarize and harm ourselves as we are seeing as a rampant practice in society today. Practices I like to encourage are to be humble. You know, are you inerrant? Could it be you're wrong? To assume good intent, I think, is super important because oftentimes people who believe differently from us have good reasons for it, and the difference can be about just prioritization of different values. Maybe one person is prioritizing a pregnant patient's autonomy, whereas another one is prioritizing the possibility of that fetus becoming a child. And neither of those is evil. They're just different priorities. And so I think many of these cases are controversial because good people can disagree. That doesn't mean you have to adopt the other person's point of view, but it can help to understand that they might be coming from a valid point of view. It can be very important to reaching some agreement to consider where you have overlap and how you can vocalize that overlap. If you can ratify the valid points of another person's opinion, that can help the argument diffuse. It can help you find shared goals. So for instance, people who advocate for access to abortion want to reduce unplanned pregnancy, and people who do not want abortions to happen want to reduce unplanned pregnancy. And so instead of arguing with each other, maybe just try to prevent unplanned pregnancy. Data acquisition can be a piece of this, just like the process of resolving ethical issues. What options do we have? What might I be missing? What might you be missing? What oversimplifications might be there? I'd say many ethical controversies in healthcare can evaporate if we learn the facts. Behaviors, and I would say get the facts from trustworthy sources. Don't just trust facts coming from people who agree with you on some controversial point. Behaviors, I've mentioned one, which is restate the other person's valid concerns, and I hope you're hearing echoes not only of how to resolve political controversies or controversies in healthcare, but controversies in relationships. Voice sympathy. Don't feel like saying nice things to that person or saying that their point is valid equals losing, because the goal is not to win, but to be right. And I think it's also important, particularly in medical stuff, to express uncertainty. So even though I very strongly believe in COVID vaccines, I also will explain to my patients areas of uncertainty, like when we didn't know if it was going to, how long the protection was going to last, or whether it was going to, a given booster was going to protect people. I say that because your credibility is supported by expressing uncertainty when it exists. Is a one-size-fits-all solution necessary? I think is a really important step. Sometimes if I believe strongly about one end of a controversy, I might sort of say, well, then everybody must agree. Skipping the gosh, in pluralistic societies, maybe not everybody loves cauliflower, but I can let others eat cauliflower even if I don't like it, and maybe there's a similar solution to that healthcare-related policy. I would say that when there is such a spread of opinions, that it is best to err on the side of respecting autonomy if possible. And I'd say that's a general rule across society if you think about it. Allow opting out is really important. So if we are making sure that patients who want an abortion can get it from willing providers, how are we also making sure that clinicians who don't want to be part of that can opt out easily and smoothly in a way that everybody wants? And as I said, focus on prevention. I was going to end the session with questions from you and then a quick moment to focus on wellness. But since we can't interact today, I hope you'll take the 10 minutes that are remaining in this time to go take a walk or take a deep breath or have some chocolate or whatever it is that works for you. I hope the discussion we had about wellness in class was helpful. Keep supporting each other. Don't believe the prestige and medicine hype because it's fake. And also, if you played this at 2x, then I hope you have that much more free time. But good luck on the final exam, and I'm looking forward to seeing you guys in upcoming classes.